Thank you very much for the kind introduction. I request all of you all, please fold your hands in front and stand for a second. And now you can sit. If you see, the amount of time taken for you to stand is not the same as the amount of time taken by the person sitting next to you or in front of you. And that is what I'm going to discuss about today. That is sarcopenia and diabetes. Sarx means flesh and penia means loss. So sarcopenia is age-related decline of skeletal muscles along with low muscle strength and or physical performance. Typically, there is loss of lean body mass, but there is preserved or even increased fat mass. And that is why the EWGSOP has staged it into 3 stages. 1, pre-sarcopenia, where the muscle mass is reduced, but the strength and the performance is normal. Sarcopenia, where the muscle mass and strength are reduced, but the performance is normal. And severe sarcopenia, where the muscle mass, strength, and performance all are reduced. There are various risk factors, including age, of course, it's age-related disorder, activity, sedentary lifestyle, sitting in the conferences for the whole day and then going to the clinics and again sitting. This is one of the factors wherein muscle loss occurs. Nutrition, both undernutrition as well as obesity, can increase the chances of sarcopenia, and chronic disorders like diabetes, inflammation, malignancies, autoimmune disorders, neurological disorders, all of this will increase sarcopenic risk. Now, why are we talking about sarcopenia? Because even in India, 4 out of 10 elderly have sarcopenia and 3 out of 100 young adults suffer from sarcopenia. And these results are just based on what we know, because most of us do not check for sarcopenia, so we might be underestimating the numbers. Why is diabetes? A patient who has diabetes will have 1.5 to 2 times higher risk of getting sarcopenia, and the muscle loss is very different because there is an excessive catabolism with insufficient anabolism and an impaired autophagy, and all of this with vasculopathy, neuropathy, mitochondrial dysfunction and inflammation coming into picture, the muscle loss in diabetic patients is much more advanced. Now, when you have a muscle damage, in a normal stage, there is inflammation, there is muscle repair, and then the muscle goes back to normal. When you have uncontrolled diabetes, there is muscle degeneration with abnormal intramuscular fat deposition, which leads to sarcopenic obesity. Sarcopenic obesity increases insulin resistance, and thereby there is a bidirectional relationship between diabetes and sarcopenia. And presence of sarcopenia in patients with diabetes will increase not only your cardiovascular risk, it will also increase your nephropathy risk, it will increase the cognitive impairment risk in the patients with diabetes. So now we are suspecting a patient with sarcopenia. What do? Remember SARC, screen, assess, radiological confirmation, and confirming the severity. The Asian Working Group for Sarcopenia has clearly stated, first you find the case, you suspect the case in the primary care setting, do a basic examination, assess for the muscle strength and the physical performance. If you feel that the patient has sarcopenia, subject the patient in a hospital setting to different confirmation processes, and where you can actually gauge the ASM or the lean muscle mass, and then you divide and determine whether the patient has sarcopenia or not. And depending upon the complications which are present, you can actually grade or stage the severity of sarcopenia, where stage 1 is there is sarcopenia but no diabetic complications. Stage 2A is sarcopenia with no impaired function but with diabetic complications. Stage 2B is sarcopenia, impaired functions but no diabetic complications. And stage 2C is having all of the 3. So there is also a rule of 2 of 3. Where if the muscle strength is reduced, muscle function is reduced, or muscle mass is reduced, any 2 out of 3 if they are present, you can confirm the diagnosis of sarcopenia. So in clinic, it's very easy to take the test. It's a questionnaire, it's a chair stand test, it's a gait test, dynamometer and squeak, which can be done in clinic, and there are specialized investigations that we can do as well. I want to talk a little about SARC-F because it's a very simple, quick, 5-item screening tool which assesses the strength, the assistance in walking, the raising from the chair, climbing stairs and falls. And the patient gives a score. 0 is none, sum is 1 and lot is 2. And if the score is more than 4, then the patient has probably having sarcopenia and must be investigated for. This is an easy mnemonic, 4C and F, chair, crossing, climbing, carrying, and then falling. Second easy thing to do is measurement of the calf circumference. So ask the patient to stand with weight equally distributed on both the legs and measure with a flexible tape the widest part of the calf. If it is less than 34 in men and less than 33 in women, it's probably sarcopenia. Similarly, a mid-arm circumference can also be used with a cutoff values of 28.6 centimeters in men and 27.5 centimeters in women. Chair stand test, which we all did right now, is also another way to assess the lower limb strength. Now, why are we assessing the lower limb strength? Because that is one of the most important aspects as far as frailty and falls are concerned, and that's why we must ensure that the patient can actually mobilize himself or herself easily. So the easiest thing is to have a good sturdy chair, place it against the wall because we don't want anybody suing us for falls, and ask the patient to sit on the chair. Then ask the patient to stand up completely and sit down completely for 5 times and calculate the amount of time taken. If it's more than 12 seconds, then it indicates a low performance. Next, you can also do a gait test, which is a 4-meter walk test. You ask the patient to walk for 4 meters at his usual pace, nothing extra, nothing fast. And if the gait speed is less than 0.8 meter per second, it's probably the patient has sarcopenia. Now, gait speed is a very good predictor of adverse outcomes in patients, including disability, cognitive decline, falls, and even cardiovascular outcomes. And therefore, this needs interventions at an early stage. This is also a clinically in-clinic test, which is a short physical performance battery test, which combines balance, gait, and chair stand test. And you can give the scores from 0 being the worst performance to 12 being the best performance. And if the total score is less than 9, then probably the patient has sarcopenia. Hand grip dynamometer is where you measure the hand grip strength. That is why they say handshakes say a lot about person than anything else. Indian populations, the cutoff values are 27.5 for men and 18 kg for women. Then comes specialized investigations. DEXA, of course, is the gold standard because we all know that different BMI may have the same lean mass. Similarly, same BMI may have different lean mass. So DEXA actually gives you a good idea about the overall picture, and the appendicular lean mass, if you calculate and index it to the height, then you get height adjusted muscle mass, which the cutoff of which is less than 7 kg per meter square in men and 5.4 kg per meter square in women as low mass. Isokinetic dynamometry is a very specialized test which is usually done for rehabilitation purposes. It has a dual purpose and is not used routinely in clinical practice. On an average, it is done in institutions. CT again can give a good idea about the muscle quality and quantity. MRI can detect fatty replacement in the muscles, which is again an important aspect. BIA will give you proportions of different body tissues, and US elastography can give an idea about muscle stiffness as well as arterial stiffness as well. So that is why it's important. There are of course newer testing tools like CT, MRI or third lumbar vertebra imaging or D3 creatine dilution test, etc., which can also be performed. Let's come a little about management. So it is a progressive muscle loss that we all are going to face. The average rate of decline is 1.2 as from age 50, and then it increases annually. It is partially reversible, but the treatment of choice is exercise and nutrition. In an era where all of us are running behind obesity, calorie restriction goes a long way, but we have to remember to balance it with nutrition. Ensure that the protein content is at least to the tune of 1 to 1.2 kg per body weight per day. Micronutrients like vitamin C, beta carotene, skeletal muscle are important. Similarly, smoking has a direct relationship with decline in the muscle mass and hence should be totally stopped. Vitamin D has given a very positive impact on the lean muscle mass and therefore should be encouraged. Exercise, as Dr. Amit rightly said, is a must. Most of us do walking, which is an aerobic exercise, but we have to do a resistance training as well, because resistance training will increase the muscle mass, muscle strength, physical performance, improve the quality of the muscles, as well as increase in the intermuscular fat also improves. This is a beautiful study where they compared the calorie restriction, endurance exercises and both, and they found that when you give only calorie restriction, there was increased muscle loss, while with endurance exercises, there was improvement in the muscle mass. So there are various pharmacological agents which are also available, but nutrition and exercise still remain the first and foremost thing. Last two slides. The action of drugs, which are diabetic drugs, also can have a bad effect on sarcopenia, especially the sulfonylureas, which should be avoided. And we have to remember, for every 10 kg weight loss, 4 kg weight loss is by muscle mass. However, the GIP-1s and GLP-1s that we now use have a relative total muscle mass as total body weight as loss as well, and therefore the index, the ratio between the total body and the muscle mass improves. So that probably it works in favor of our patients. Similarly, this is my last slide, sir. This is one thing which was a systemic review of 38 publications which gave a very salient points. One, skeletal muscle is the largest metabolically active tissue. Approximately 50% of the whole body protein turnover is in the skeletal muscles, with 70% of PP glucose disposal being in the skeletal muscles. The lower levels of muscle mass have been increased risk of every other complications in the body. Ratio of body weight to muscle mass is improved with the use of GLP-1. Weight regain after weight loss is mostly due to fat, and that is what we have to always remember. Recurrent cycles of weight loss and weight regain actually harm the patient and cause adverse metabolic effect, and you have to start conservation of the muscle mass as early as possible. So from today, we should get up and sit down as many times as we can, and not only for us, we have to ask for conservation of muscle mass right at the young age. Thank you so much.